that point of view. There's two types of intubation. Sorry, I'm just going to remove this. I don't have COVID. So there's what we call and what we're going to concentrate on now, which is rapid sequence intubation. All right. And the other one is called delayed sequence intubation. Now, delayed sequence intubation is something that you see more commonly in anesthetics, in theater. Okay. We also use it in the emergency department. But rapid sequence intubation, what it basically means is that you've got to do it quickly. All right. That's basically what it means. Now, all the things that I'm going to show you now are basically going to happen concurrently. So it's not that you get the drugs ready, then you position the patient, then you pre-oxygenate the patient, for example. What you are going to do is that you're going to do all of these things at exactly the same time, right? So that's what RSI, rapid sequence intubation. So if you go to the first slide, then it kind of shows you what we have, right? So those of you behind can see, all right? So these are the tenets of rapid sequence intubation, all right? So we plan, all right? And we're going to go through each of these in a small way. So what are my chances of an easy intubation? So if I know I'm going to have an easy intubation, my planning is easier. If I'm suspecting I'm going to have a difficult intubation, my planning becomes a bit more intense, all right? I need to prepare. I need to have all my equipment ready. So that's suction, backup, monitors, tubes, things like that. So I need to have all of that ready. Okay, we'll go just a little bit back to the other position, all right? So generally the head is a little bit up, okay? So you're not absolutely flat. Unfortunately, for most of you who work in the South African public service, if you have a working bed, that's amazing, all right? So majority of the time, you just take what you can get, okay? But ideally, the head is up by about 30 degrees, all right? EAC, external auditory canal, all right? The little hole on the side of your head, in line with your sternal notch. Okay, that's basically what we aim for. So in other words, it mustn't be too far forward, mustn't be too far back. That's a nice way of saying it, all right? You pre-oxygenate, which we pre-oxygenate with a bag mask valve, all right? So we're going to have a look at that. We paralyze and we sedate with drugs to prevent what they call the intubation reaction. And also because if I try and shove a big straw down your throat, you're going to fight and scream no matter how much I explain it to you. Okay, and then of course you want to confirm that the tube is placed, all right? So we're going to cover all of these things for a few minutes, and then you guys are going to practice on the dummy, all right, as best as we can. So the first thing is when we're planning. So you guys may have heard, it's called the Malampati score, all right? Now, all of these scores were developed by anesthetists who do what we call pre-anesthetic ward rounds, okay? So pre-anesthetic ward rounds are when you go around. Have any of you had your tonsils out or been for any procedure? The anesthetist came to see you before that. He asked you to open your mouth and stick out your tongue, and he checked your back and he pretended to listen to your chest and things like that, right? So in essence, what they are looking for is that they are looking for Malampati 1 to Malampati 4. Malampati 1, you can see the tonsillar arches are very easily viewed. You can see most of the larynx. You can see that there's quite a bit visible, basically, all right? So what that tells them is that it's going to be an easy intubation, all right, more or less. And Malampati 4, where you can hardly see anything, all right, the one right on the end, okay, where you can't even see the tonsillar pillars, you can just see a bit of the soft palate, things like that. It tells them it's going to be a difficult intubation. So that means they have to plan a little bit more, okay. Now, in the context of an emergency department, you don't have that luxury, but it's just a nice score to know because visually, quickly, we can kind of decide, is this going to be easy? Or is this going to be difficult? But now we're just talking about general intubation. So if you have the chance to have a look at your patient before, this is the first score that you use, all right? Now it's got very specific guidelines as to what you can see, but just by eyeballing it, you can see that we're looking mainly at the tonsillar pillars and the amount of the, the oropharynx that we can visualize, all right? And you can see that that slowly decreases between 1 and 4, okay? Then the other score that we use is called the Lemon score, all right? So the Lemon score is also mainly used in anesthesia when you have time and a stable patient. In the ED, we also use it, but we use the basics of it. You can't use it in its full, to the full extent because you simply don't have the time. By the time you go through all of these, your patient will be dead. So but you guys must learn it from both points of view, right? From an emergency and a stable point of view. So the first one is look externally, all right, which kind of makes sense, all right? So you're looking for external markers of difficult intubation, right? So body habitus, fat or thin. Generally, the larger your patient, the more difficult the intubation. The thinner, longer. Let's just say shorter, bigger, more difficult. Thinner, longer, it's more stretched out, the easier your intubation. All right. This has to do with your neck mobility and the distances and things like that. Okay. So your head and neck anatomy. So short neck, right? Always a problem. You know, you get the, we know we have a lot of those patients who come in like that, right? They, if you see them run, okay. If they ask you to intubate, pretend you've got diarrhea and just run away, right? So a small mouth. Okay, so we've seen patients with small mouths, we've seen patients with large mouth. It's easy to tell the difference, all right? So small opening, loose teeth, false teeth, right? Things like that, prominent teeth as well, right? So these are things that you have to look at. And jaw abnormality, right? So we've seen people with an underbite, overbite. Both of those make it a bit difficult, right? And beards, right? It's not actually that difficult. It's more to put the mask on that it's a problem, okay? So you can go yours. Fine. Okay. All right. Then the evaluator, right, which is a 3-3-2 principle, right? So can the patient for 3 fingers between the inside? That's good, right? Not good. Less, bit of a problem, right? So patients have had previous jaw surgery, trauma, things like that, because it's going to be more difficult for you to put the laryngoscope inside and manipulate. Okay. Is the mandible length 3 fingers from the mentum to the hyoid bone? So mentum, all right, to the hyoid bone. All right. So you can say I'm an easy intubation, actually. All right. So that's basically what they're looking at, all right? And the distance, the last one is from the hyoid to the thyroid. All right. So your hyoid bone at the bottom, your thyroid more or less here. So you're looking at about that space there, if I remember correctly. All right. So basically we have those, and that's what you're looking at. Then the Mallampati score that we talk about, obstruction or obesity. All right. So basically patients who have any sort of growth, swelling, anything around the upper airway will present a challenge. All right, foreign bodies, things like that, thermal injuries, all of that, what they talk about. And of course, like I say, a patient who's very large, it does become difficult, right? And then the last one that you check for is neck mobility, right? For the simple reason that you want to be able to extend the patient's neck, right? So think of sniffing. So in other words, it's something, that's how you want your patient, right? But some people can't get their neck that far. It's stuck like this. And of course, you don't want to hyperextend as well, which I'll explain to you now, because I've seen a lot of the young, they immediately catch the patient, they do that, all right? So that's also not good, okay? So what do they say of your sniffing position? Optimal laryngeal view, okay. Neck mobility can be significantly reduced in patients with trauma, and especially if you work in an emergency setting, cervical collars are very common. Elderly, those with arthritis, okay? All right, so these are your things that you need. Okay, so just to go through, so your laryngoscope basically is a handle with a blade, with a light, so that you can actually see what's going on. All right, now they are designed to be used by the left hand. One day when you become a famous anesthetist, you can ask for the right-handed one. Your hospital will buy it for you, but it's quite expensive. Okay, until that time you have to use the left hand. All right, so any lefties here? Oh, sorry. Okay. But you're a lefty, you've been disabled your whole life. So you just have to, you're used to managing a challenge. Okay. I'm just joking. Right? Our mask, okay. Nasal, oral airways, okay. Tape for securing, although we don't really use this. Then your endotracheal tube. Now this is one with the stylet, all right, what we would call an introducer, which we don't really, I didn't bring it here, but you know, the most of you would have seen something like this. The 12 ml syringe is to test your tube, all right, which we're going to talk about just now. Yankawa suction, all right, which is a specific type of suction, all right. So the Yankawa is the rigid suction, okay. Those floppy ones that we have, those are just normal suction catheters. You use what you have, okay, basically. And then a boogie, all right, or bougie, whatever you want to call it, all right. So a bougie is there to help you basically get into the area. All right, so the advantage of a bougie over a tube is quite simply the size. It's extremely thin. So if you can just see bits of the airway, the bougie allows you to go in there, and then the tube runs over the bougie. So you know that you're and it's fine. Okay, and you can see it's got a little tip at the end, which we'll talk about just now, right? So that's mostly your equipment. Of course, your monitors, you need to know saturation, BP, heart rate, all of those things that are going on. This is a basically a carbon dioxide detector, right? So these are the most common ones that are used, but we don't have them. So what happens is once you're in the airway and carbon dioxide is expelled, they change color. So it tells you that that is carbon dioxide. Because if you get into the stomach, carbon dioxide is not taken out, right? Then you prepare, all right? So back up. Any idea what this is? On the next page, any idea? I mean, on the next slide, any idea what this is? What it's called? So that's a laryngeal mask airway. Okay, so a laryngeal mask airway is basically a mask that fits over your larynx. So it's meant for internal insertion. All right. Now, since you guys have never seen it, I didn't bring one, but before we finish off, I'll go and bring one, right? While you guys are practicing, and I'll show you guys how we actually use this. All right. So this is a life-saving device because it doesn't need a laryngoscope, it doesn't need experience, it doesn't need anything. It just needs KY jelly and a bit of force, and it gets in there, and it can actually save your patient. All right. So in other words, it's a backup air. So when you can't get a tube in, but you still need to get oxygen in, you can actually use this. Now, there's a lot of theory when it comes to this, but the basic thing to remember is that it can substitute for an endotracheal tube. You can ventilate through it. If it's inserted properly, it has all the advantages of an ET tube with none of the disadvantages. Okay, so it's a good thing to know about, right? Go to the next slide. This you guys should all know. Okay, that's a bag mask valve, right? Setup. Okay, so you have the mask, okay, which should be correctly fitted to the patient's face. You have the main bag, you have the reservoir bag at the back, you have all the little things that go along with it. You have the PEEP valve. So the PEEP is positive end expiratory pressure. So in other words, it keeps a little bit of pressure in the lungs. And you have the pop-up valve, which is basically used more for kiddies. So when you want to inflate the lungs, you don't want to inflate them too much as well, because they are balloons. They can just pop. So you want to make sure that you have a little bit of control, right? So for kiddies, there's a little, I didn't bring the valve, but if you have a chance, just look at it. You'll see it has a little screw off top and screw on, right? For adult and for child. Okay, so we'll go to the next one, right? So you'll see that it just says pre-oxygenate at the bottom. So there's two ways of holding the mask, right? So the first one on the left-hand side is one-handed. Okay, so that one-handed one is called the EC method, all right? Because if you look at these bottom three fingers, it's making an E. If you look at the top two fingers, it's making a C, all right? So the EC method. So the three fingers are there under the jaw to help lift it up. Because when a patient goes limp, all of this falls back, it starts obstructing the airway. Pull it forward, and because of the attachments of the tongue, it pulls the tongue forward as well and opens up the airway. So that's why we do that, right? So, and you can see even on the two-handed one, they're doing a double EC. It's for the same principle. You're just trying to pull it up, all right? And then the C is to try and maintain balance on the mask itself. You're holding the top and the bottom in place because you don't want any leaks, all right? So the one-handed method is a more common one that we use simply because we always never have enough people on a research. But if you have enough people, then the two-handed method is, of course, much better. You have much more control and a much better seal, all right? So I think you guys did the BLS course with Dr. Moses. Some of you did it, isn't it? I'm not sure if you'll practice that. Okay, we'll practice it one of the days. Maybe I'll have to set up just a weekly session with you guys just to show some of the basics, all right? But anyway, we'll just concentrate on intubation. And then we paralyze and sedate, all right? So we paralyze so that the patient is not moving while we're trying to get it, all right? So with the dummy, it's very nice because the dummy never moves, no matter what you do, okay? But patients move, all right? Unless you have a patient who's completely unresponsive, the patient is going to move. So you use succinylcholine. That's the most common. But there's a lot of types of muscle relaxants, right? That's where I put it under paralyzed. So SUX is a depolarizing muscle relaxant. It's the one where the patient fibrillates. I don't know how else to put it, before they become completely relaxed. And then you have others like rocuronium, vecuronium, which are non-depolarizing. So the patient doesn't move, they just become relaxed. Now, because SUX is the most common one, it's 1 milligram per kilo. That's basically the easiest one to remember. So you have a 50-kilo patient and 50 milligrams. You have a 100-kilo patient, you can use 100 milligrams. So that's the easiest one. Okay, and then Dormicum, sedate. All right. Why do you want to sedate the patient? Because it's traumatic. If your patient even has some sort of responsiveness, how are you going to respond to something being shoved down your throat? Your BP is going to go up, your heart rate is going to go up, and it's going to go up to dangerous levels. All right. So it can precipitate tachyarrhythmias, and it can precipitate CVAs, bleeds, all of that, because your BP is just shooting up. Okay. So you need to sedate your patient. In other words, your patient mustn't be aware of what's going on. And it also makes it easier for you to then ventilate the patient, because otherwise you're going to be breathing against the tube if you were the patient. So by keeping you nice and calm, we breathe for you. Okay, so those are the basic tenets of it. Okay, so how do you keep them sedated? Now it's very all well and good, you've gotten it in, but the patient's going to start waking up. All right, so there's a few ways that you can keep a patient sedated. So number one is morphine. All right, it's a very good drug, makes the patient high, but also sedates them. So they're completely out of it. They don't know what's going on. All right. Then the other one is Serenase, haloperidol, if it's available. All right. So it's mainly used in psychiatry. All right. We haven't had it in stock for some time in South Africa. But if you have a chance to use it, oh, it's a wonderful drug. It knocks them out completely. They have no idea what's going on. And the nice part is because it's got a good side effect profile, relatively speaking, you can actually go up quite high. So you can use 5, 10, 20, 30. I've seen one of our anesthetists went up to 40, 50 milligrams per patient just to keep them sedated. So it's quite a nice one to use. And then, of course, you have dormicum itself, which you had given initially, but you may want to run it as an infusion. Okay, so the easiest one to remember that I always give the guys is 50 milligrams of dormicum in 200 mils of whatever you have. All right, whatever you have, and you run that at 50 mils per hour. All right, so it's 50 in 200 at 50. Easy way to remember it. You're basically giving 12.5 milligrams of dormicum per hour. Okay, so you're running at, 1 milligram every 5 minutes, which doesn't sound too bad when you look at it. Okay, you know, if you had to stand with dormicum and give 1 milligram every 5 minutes, you're not actually giving that much. Okay, and then you can adjust this up and down. So if your patient is not sedated, you can go to 60, 70, 80, but it's very rare that you need that. Alternatively, if your patient is too sedated, you can go down 40, 30, 20, things like that, right? And especially if you're in an emergency situation, it's the easiest one to remember. The hardest thing to do in an emergency is try to remember complicated formulas and, you know, work out exactly to patient's weight. So it's easier to remember quick things, okay? But when you're in anesthetics with Dr. Bubaker, then you got to know precise, okay? Because they work in a different setup altogether. So next one, all well and good. Now you've got your you've got your laryngoscope in. What are you going to see? So these are all the things that you are going to see, all right? And that's a perfect view of the what you might call it, of the larynx over there. Okay, so very rarely will you see it exactly like that. This was actually taken with a video laryngoscope. All right, so that's a laryngoscope that has a little fiber optic camera at the end, and you're actually looking from the outside and you can see what's going on. But it gives you a good idea of what's going on. So it's the epiglottis, the cricoid ring at the bottom. But the most important thing is the true cords. All right, that's what you're actually aiming for, and that's what you're aiming to get in between. Okay, so if you can look at the bottom, you can see that interretinoid notch, okay, or posterior cartilages. If you go below that, you're going to go into the esophagus, and above that, you've got the epiglottis, right? So really, you're aiming to go in between those cords, okay? So if you can't see those cords, if you can see something else, but you can't see those cords, chances are you're looking at the esophagus, okay? Because the esophagus is also a nice round ring, but there's nothing there. It's just a round tube. That's it. Okay. So you've got to be able to see those cords. And if you can see those cords, you know you're in the right place. And that's what you're aiming for. All right. Then it becomes a video game, point and shoot. Okay. So you're looking at them and you're trying to get it in. Where do the problems come about? Sometimes as your tube is going in, it blocks your view. All right. So you kind of got to really know where you're aiming at. Or you've got to insert a bougie or introduce it before or things like that. But it comes with practice. Don't worry. Okay. So how do you hold a boogie? All right, so this is the next one is just a joke. That's how you hold a booger. That's not how you hold a bougie. All right. So we'll go to the next one. So this is a bougie. All right. So there's two ways that you, or actually three ways that you can use it. All right. Now, unfortunately, we don't have one here, but because it's a long thing, all right, basically you don't want to hold it like a spear and try and get it in, because then the front part is a bit too mobile. So you can't actually direct it to where you want to go. So the first one that you'll see there is the shaka grip. Now that's actually, the easier way to remember is the hang 10. All right, you all remember hang 10, you were small when hang 10 was popular, but it was out there, right? So basically what happens, the back end goes out that way, and the part of the tip is controlled by your little finger. All right. So whichever way, you hold it out straight, you hold it there. So basically what it's done is it's shortened the bougie so that you can actually maintain more control as you move it a little bit up, a little bit down. Then the key way or the trigger style is where basically you bend it over and then you use that also, all right, to get it in. And you can have the tube over before, you can have it without. The decanter one that you see at the top is just where they push it through the opening of the ET tube. It's just to give you basically a few ways that you can hold it. But the most important thing is don't hold it like a spear and try and get it in. It becomes very uncomfortable. You've got to try and shorten it a little bit. Okay. The most important thing is that little tip at the front. Can you see that? That needs to always be pointing upwards. All right. Why that is because as you're going in, it also gives you the feeling of the tracheal rings as it's going through. So you feel like a little bump, 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 bump. So you know that you're in the right place. Okay. If you don't feel that, you're in the esophagus. All right. Because your tracheal rings are like that. So if you're in the esophagus, you won't feel anything. But as soon as you're in the trachea, you'll actually feel it. All right. So it actually gives you a good one. All right. So this is how you use a laryngoscope. Okay. But we're going to practice this. The reason why I use this one is because a lot of people feel that you need to do this with your wrist, which is like a motion going forward. That's not it, actually. What you're trying to do is lift. All right. And we're going to practice that just now. You're actually trying to lift. Okay. So that's the basic thing. All right. And then you have to practice it. All right. So the question is, when do you stop your tube? All right. These are things you can just keep in mind. All right. So you stop the tube at 3 times the diameter. So to give you an example, a size 7 tube, you stop it at 21 centimeters, 3 times 7. All right. So you go into 21. If you have a size 8 tube, 24 centimeters. You have a size 6 tube, very good, 18 centimeters, right? Okay, I'm not going to do size 5 tube now. Okay, support, you always support the tube. It can move in and out very easily, all right? You must measure your OP airway, which I'll show you guys how to do just now, but basically it's from the corner of the mouth to the angle of the tube, all right? So it shows you that that's the correct size for the patient, all right? You must listen, you always listen for air entry over both axilla and over the stomach as well. If it's in the stomach, you'll hear as air is being forced through the gastric fluid, all right? And you watch, you look for the saturation to stabilize, all right? It may not necessarily go up, but at least it should stabilize. It shouldn't go down, all right? So that's the end of that little presentation, all right? That's just a joke to finish off, okay? But what we're going to do now is that we're going to actually practice on the dummy. Okay, so let me just stop this here.